Doctor, what's your sense of this? And I want to go back to that Wall Street Journal reporting. It's not a scientific analysis. It's more anecdotal that physicians were telling a reporter that their impression was, in their experience, about a third of the negative test results we're getting, they were thinking were wrong.
Thanks, Lawrence, for having me. It's just interesting. It's both the anecdotal, and one of the New York Times opinion pieces that I saw actually quoted a Chinese study that looked at testing of patients who had this disease and showed that in certain number of people who were tested, even though they were confirmed to have the disease, sometimes the test was negative. So this is complicated, right? I think for the person on the other end of it who's waiting for their test, it doesn't matter what the reason is why it came out to not be positive when they themselves had the disease. But the reasons for why a test could be potentially false negative, the idea that it could be negative when there's disease there, is multiple. So one, actually, it's the virus itself. How early in your disease are you getting tested? So we know for a lot of these tests, if you are early enough in your disease, it may not be as accurate because it's not going to pick up the virus because the concentration of the virus is not that high. As the disease is progressing in a patient, how is the virus acting? And that's part of this disease that we're still learning about. How does the virus move through the body? Where does it concentrate as the person gets sick? Then there is the test itself. And as has been talked about before, a huge number of these tests that are on the market right now are looking for the genetic material. They're the nucleic acid tests out there. They're looking for the genetic material. And so by the time a test gets an FDA, even an emergency use authorization, it has a little bit of, a guarantee that it will at least detect the virus to a limit of detection, whatever that limit of detection is that they have set when it's set out. But here's the toughest part, which is most of the times when there's no outbreak, we take a new test and we take it for a clinical test drive. We call that clinical validation of a test, just seeing that even if it's accurate in the laboratory, how does this play out in the real world? And that's where I think it gets more complicated. So how sick were you when the test was done? Was the test gathered in the right way? Was the test performed how it should have been? And all the reagents that were needed in the laboratory were there and performed in the right way? And then lastly, by the time the sample came to the laboratory, was it appropriate enough for it to be tested to meet that limit of detection? It's all very complicated, but in the end, all this to say, we are seeing this, clinically, we're seeing this in our care here as well, that there are portions of people who come in who clearly have this disease and on a subsequent test end up having this disease, but early on may not be positive on the test.